Hi, and welcome to this session on navigating recurrent pregnancy loss. I am Megan Hanson, and I'm here with Dr. Mak. And we're going to talk to you from two perspectives, somebody who has lived the experience of recurrent loss and somebody who has dedicated their career to treating people like us. So without further ado, I will go ahead and get started. Let's see. There we go. So what we're going to do today, we'll quickly go through some introductions, just briefly. I know our bios are in the site, but just so you know a little bit about each of us and our backgrounds. Dr. Mak is going to talk to us about what the definition of recurrent pregnancy loss, how she usually goes through workups with the couples that she treats, how she handles it when she's in one of those situations that many of us have faced where everything comes back looking normal. And then after that, I will take back over and talk about some of the kind of emotional and psychological things that are very common, that I'm sure many of you already are dealing with. And talk about some places where you can go for support. And then we'll wrap up by talking about some new research that's happening and how you can participate if that's something that interests you. But before all that, I want to just pause and say that we're really sorry. If you are coming to this session, it is probably because you or somebody that you care very deeply about has experienced recurrent pregnancy loss, and that sucks. It is just a terrible, heartbreaking experience. And while we're really glad that you're here and that you found this space, we're sorry that the reason that you're here is because of that. So just a bit about me. So I'm a Midwest girl living in the Pacific Northwest right now. So I'm in Seattle. I have been with my husband a very long time. We met when we were 19. I am now 40. We experienced 6 early pregnancy losses when we started to try to grow our family in 2015. We ended that part of our journey with very few answers, a lot of sort of partial diagnoses, a lot of tests, a lot of medications, a lot of procedures, and not a lot of success. So in 2019, we decided to stop trying to grow our family naturally and moved on to gestational surrogacy. In that time between when we stopped trying and actually became parents via surrogacy, we started Recurrent Pregnancy Loss Association. I will say that my story then took an unexpected turn, and I actually did have my first successful pregnancy, my 7th pregnancy at age 40 this year. So I guess all I can say about that is life is chaos, but there is hope. It sometimes works out, although sometimes it doesn't. So I want to be really respectful of both of those possibilities. And I think that's it. That's a little bit about me. Oh, no, sorry, one more thing. Quick bit about Recurrent Pregnancy Loss Association. So we are a nonprofit organization, and our mission is really trifold. So one, really focused on eliminating recurrent pregnancy loss, wanting to not have this happen to any other couples. And so that part is really focused on advancing research, doing what we can to be partners with the medical and scientific community to help them find answers faster. We also provide a lot of support and resources to people that are going through this, and do a lot to just raise awareness and advocate for this community. So you can see some of the things that we do. We have annual research grants. We have a monthly support group. We do a lot of other kind of community activities. I encourage you all to visit our website. If you don't know anything about us and this is the first time you're hearing about us, please visit our website, get to know us a little better, and follow us on Instagram or Facebook. That is really all I'm going to say at the beginning, and I'm going to pass it on to Dr. Mak to introduce herself and start telling me more about recurrent pregnancy loss.
Hi, I'm Dr. Winifred Mak. I grew up in a small town near London. I have a PhD in genetics, and I am a reproductive endocrinologist and infertility subspecialist, and I've chosen to really specialize in recurrent pregnancy loss. And so I'm really passionate about helping my patients. And the other part is that I'm active in research. I have a translational program that I really now focused on studying recurrent pregnancy loss so that I can help my patients through both caring for them and also through my research. And on the side, I started a blog called Miscarriage MD. And so I created that to really sort of distill the research in this arena because it's so much and the quality is very variable. So I try to sort of put little nutshells and make it as layman so that patients can sort of understand the research that's out there. So I'm really excited to talk to you guys and sort of share my experiences of taking care of patients with recurrent pregnancy loss.
I'm going to just pause right here or interject right here because Dr. Mak is so humble. So I'm going to toot her horn even more. And just, I want everybody to know that there are a very few number of doctors in the US that are truly experts in this and actively researching about recurrent pregnancy loss. There's not very many of them. And Dr. Mak is like one of the experts. And she also does consults. So, and she's just been a huge supporter and advisor to the organization. And even more excitingly, she was the recipient of our research grant this year. So you guys are really talking to the best.
Thank you. All right. So I was going to start with definition. So ASRM is the American Society of Reproductive Medicine. So that's a society, national society for people, doctors in my field. And so recurrent pregnancy loss is defined as a disease when you have 2 or more failed clinical pregnancy. And what's a clinical pregnancy? A clinical pregnancy is if you've had an ultrasound, that you've seen a sac, or that you've passed. So histopathology is that you actually had a miscarriage where you pass actually placental tissue. And ectopics are not included in the definition of in the recurrent pregnancy loss definition. Molar pregnancies and biochemical pregnancies are not. For the American Society of Reproductive Medicine. What I would throw in there is that in the European Society, they do include biochemical pregnancies. So in my practice, I definitely include biochemical pregnancies in my count of failed pregnancy losses. So how common is it? So definitely having a miscarriage in the first trimester, so the first 12 weeks, is common to have just one. And I tell my patients who are not recurrent pregnancy loss patients when they have a miscarriage that hopefully this is your only one that you'll have. And it is common, 15 to 25% of women will have at least one. And the cause for those miscarriages are usually there's something wrong with the baby, that there's something wrong with the chromosomes. So majority of pregnancy losses are due to that. And then unfortunately, about sort of less than 5% of women will have 2 miscarriages back to back. And then even more rarely, less than 1% will have more than 3 back to back. And really, it is psychologically devastating for all patients, even to have one loss. But to have multiple is even obviously, and probably if you're in this session, then you guys will totally agree that, you know, having multiple is you know, and Megan will share her experiences with that later. So so as I said, you know, most, you know, one-off miscarriage usually something wrong with the baby due to chromosomes. But as a woman or a couple go through more miscarriages, it is probably less likely that there's actually something chromosomally wrong with baby, and maybe there's some other causes. But I would highly recommend, if, to have chromosomal testing for at least your second miscarriage, because if that, if it comes back abnormal, then you have your answer. And I think it's really helpful for patients that I take care of if they, in the past, they've never had testing. But obviously, this is really educating OBGYNs that really the second loss, let's do some chromosomes, because it will provide an answer right, immediately. There's something wrong with the baby. Gosh, that's the reason why you miscarried that baby. And then really, if the miscarriage is a normal chromosome or euploid pregnancy loss, then we definitely want to be starting up the recurrent pregnancy loss workup. So here on the right, you can see here chromosomal abnormality could be due to various using egg, sperm, any genetic issues. And then if it's chromosomally normal, then it could be still a genetics that we just haven't got the test to test for, anatomical, something wrong with the uterus, and then endocrine and hormonal, and then autoimmune. And a big proportion, and many of you may have, be here because of that, is that there's 40 to 50%. We've done all the testing and everything is normal. So here I get more sort of granular about the causes. So cytogenetic means that mom or dad may have wonky chromosomes. I tell patients, they may have something called a translocation, where the genetic information is from one chromosome has attached to another, and they kind of swapped. So this is not that common, 2 to 5%, but that definitely is a known cause that we can treat. There's something called antiphospholipid syndrome. I'm sure most of the people in this room, if you have recurrent pregnancy loss, you've heard about this. And so this is a more autoimmune cause. And about, on average, prevalence is about 15%, but it can vary between different populations. So the anatomic that we talked about, it could be a polyp in your uterus. So this is a growth inside the lining of the uterus, usually benign, nothing scary like cancer. It could be a fibroid, which is like a proliferation of the muscle of your uterus. And if it pooches inside the uterus, then that could increase your risk. Scar tissue, so something if you've had any instrumentation of the uterus, such as a D&C, or you've had a baby and you had to have a postpartum curettage, you may have scar tissue. So that could increase your risk of having miscarriage. And then a uterine septum is something people are born with. They have instead of having the uterus be one whole cavity, there is a separating wall between the inside the uterus, which is called the uterine septum, and this can be surgically removed. So on average, about 12.6% of patients may have that. And then hormonal and metabolic, so this could be hypothyroidism, which is underactive thyroid, diabetes, hyperprolactinemia. So there's a hormone called prolactin. If it's elevated, that could change the lining of the uterus that may predispose to miscarriage. So about 10% of patients may have that. And then, as we talked about, a large proportion, we do all the testing that the ASRM suggests that we do, that it comes back normal. And then we're left with unexplained recurrent pregnancy loss. So I wanted to introduce sort of some new things, so new kids on the block of other causes that I think that, so our bulletin for ASRM was It's 2012 and it's pretty outdated. So there will be probably new things that will make it to the new iteration. And so chronic endometritis is one, which is an inflammation of the lining of the uterus, which has been associated with recurrent pregnancy loss. So women with recurrent pregnancy loss, about 20 to 30% may have this. And the treatment for this is antibiotics. And, everything that I've told you about has focused on the women. What about the guy? There is an association between couples, the male partner having something called increased sperm DNA fragmentation. So this is, DNA is the genetic code. And in sperm, obviously, have the genetics from dad. And then sperm DNA fragmentation is that they have breaks in the DNA that could basically make the integrity of the DNA suboptimal, which could also lead to issues with miscarriages, that the baby may have issues with development and increased risk of being lost. So these are, it could be leading to abnormal chromosomes, but it could be leading to more subtle things like single genes are more likely, or, there are many breaks in the DNA that overall will disrupt many genes, therefore causing baby to have issues and therefore be lost. So the next few slides are kind of my routine workup, and it doesn't necessarily mean that everybody has to do this. And then the pink things are what really I do that maybe other REIs may not necessarily do in their standard practice. So for the women, you can see a long list. So we do chromosomal analysis. So that's karyotype to look for the wonky chromosomes. I do a thyroid function testings and antibodies. So TSH and the antibodies of the thyroid. Hemoglobin A1C is to look for any prediabetes, diabetes. Prolactin, as we talked about, elevated prolactin levels can be associated with miscarriage. And then to look for antiphospholipid syndrome, we do the antiphospholipid antibodies, which are listed here. We usually, to actually roll in for that, you have to repeat these tests twice, 12 weeks apart. And if one of these are positive and highly positive twice, then yes, you have antiphospholipid syndrome. And then saline ultrasound is to look for the issues with the anatomic sort of uterine issues that we talked about, polyp, fibroids, septum. And then when I see my patients for their saline ultrasound, I do something called an endometrial biopsy to look for the chronic endometritis. So that's why it's in pink. Not everybody does that. And then for the men, usually the only thing that most people do is just look at their chromosomes to make sure they don't have wonky chromosomes. But I routinely look at the semen analysis, like a routine semen analysis, because there is some literature that suggests that sometimes the semen analysis is abnormal, mildly abnormal. And then I do a sperm DNA fragmentation test on my male partners as well, to look for the increased sperm DNA fragmentation. So how do you treat recurrent pregnancy loss? So basically, if we identify the cause, then that's easy. We go ahead and treat it. So for instance, if you have thyroid disease and you have hypothyroidism or underactive thyroid, we treat with levothyroxine. So we supplement. And I think it's really important once you're pregnant to have your thyroid checked out immediately, so you can adjust if that is one of the causes. Obviously, if you have uncontrolled diabetes, we definitely want to treat and optimize you before you actually try again. So we may treat you with metformin, or if some people may need insulin. And so we have to work with your endocrinologist to optimize your hemoglobin A1C, because I think that's really important if you have diabetes, that your hemoglobin A1C need to be tightly controlled. for antiphospholipid syndrome, the treatment is baby aspirin before you're trying to get pregnant, and when you are pregnant, to use heparin. And in the studies, they use unfractionated heparin, which is very difficult to titrate. So nowadays we use Lovenox. So a lot of people may be familiar with that. So the chromosomal translocation, so the wonky chromosomes, either mom or dad, then we can do IVF and do genetic testing of the embryos for these structural abnormalities. So it's called IVF with PGT-SR. So definitely we can offer patients that possibility to decrease chances of a miscarriage due to the baby having the abnormal chromosomes that are off. So that is definitely something that can be offered. And then if there's a structural issue of the uterus, such as you have a polyp, let's remove it. And that's a surgery called a hysteroscopy, where we put a little camera inside the uterus and then we remove the polyp. So day surgery, not super invasive. And then if you have a fibroid where it's pooching in and distorting your uterus, again, that's a day surgery where we put the camera in and we basically shave off the fibroid. Scar tissue, we use little scissors to cut the scar tissue, and the septum, again, we cut the intervening wall that shouldn't be there to make it the uterus a whole cavity. And then I think I alluded to chronic endometritis. So it's inflammation, and the organisms that usually we think of are not sexually transmitted diseases. So I have a lot of patients say, oh, is it something that it's sexually transmitted? Usually isn't. It's usually some imbalance inside the sort of the normal bacteria. But the treatment, as far as we know, is antibiotics. And then I would rebiopsy my patients after they have had the treatment to make sure that it's improved and kind of go from there. So what do I do for my patients who have done all those things and, and we're left with, we don't know why? So my approach is to suggest something called luteal phase vaginal progesterone. So this is sort of, my patients will do ovulation kits, and 3 days after they have the surge, obviously they try and get pregnant, and then they will start vaginal progesterone. And the reason why I do the luteal phase and not with progesterone when you're pregnant is that the big study that looked at starting progesterone when you're pregnant really showed no difference in the live birth rates between the people who got the progesterone and the people who didn't. There was some evidence that if you've had 3, 4, 5 losses, that it does help in those patients by increasing it by a small percentage, like 3%. But there are other studies that suggest that maybe we just have to start the progesterone earlier. And so that's what I do, is that if the study showed that it was no difference when you started with pregnancy, then I want to go earlier. And so when they are pregnant, then I will increase the dose to similar to the studies that have been done. So I start with a lower dose, after ovulation, and then increase it when they're pregnant. And then the other thing I do is something called tender loving care protocol. And so this was started, a research study in England in like the 1980s that looked at recurrent pregnancy loss patients. And half of them went to just do routine care, prenatal care, and then the other half had the supportive care or the tender loving care, which meant that they were seen in an early pregnancy unit and they were seen every week for an ultrasound until 12 weeks. And so those patients who had the tender loving care had an increased likelihood of having a live birth compared to the people who just had routine care. So it's really supportive care. What is the magic? We don't know, but for my patients, we're very high touch. And so when they first get pregnant, we do the HCG levels, the pregnancy hormone levels, and we repeat that every 48 hours. And When it's above a certain level, then I'll see them weekly for ultrasounds until we get them past the time that they had their latest loss. So that's what I call as my sort of, for my unexplained recurrent pregnancy loss, these are the two approaches. And so, I think, with this approach, many will go on to have an ongoing. And is it because we did just supportive care? We'll never know.
Dr. Mak, I'm gonna throw a question at you because I'm sure it will come up in the chat, and I'm confident you can answer it. But I know, some of the things that are not on here that I know a lot of people ask me about, like when they send questions. So I noticed that there's nothing on here about testing for inherited thrombophilia. There's nothing about immune protocols. Nothing, and also the sperm, how do you kind of treat the male partner? So can you comment on any of those pieces as it relates to this unexplained population?
Sure. So the inherited thrombophilia, we only test that if you've had a, personal history of blood clotting. And I only do that if you've had a later loss, like a second or third trimester loss, because so in the first trimester, there is no blood flow in the placenta, minimal. So really the inherited thrombophilia where we're thinking increased risk of blood clot probably doesn't pertain to early losses. But yes, if you've had a second or third trimester loss, I definitely do the inherited thrombophilia panel. And if you were positive, then we would do the baby aspirin and the Lovenox. So immune protocols. So controversial area. I think that I truly believe that there is an immunological cause, but however, the testing is controversial, whether the NK cells elevated, does that make sense? We just had a whole postgraduate course on sort of the new horizons in recurrent pregnancy loss. And I brought my colleagues who are in basic science, and I had my colleague who has a PhD in immunology. And I tasked him with, tell us as clinicians, what do you think about the immunology part? And he truly believes that there's an immunological part. However, the tests that are being done don't really address the actual, what, sort of biologically we think that immunological issues could cause miscarriage. So I think it's out there, and there's a lot of, talk about immune protocols. So I think it's really too, and I don't really recommend my patients go down that route unless they actively ask me and say, hey, Dr. Mak, we've exhausted everything. I want to go down that route. And I was like, okay, we can sort of look at that. And then the sperm part. So there is definitely an association between increased sperm DNA fragmentation. However, we don't have the study or yet to see what would help decrease the sperm DNA fragmentation for recurrent pregnancy loss patients to actually make a difference. But I would say that, we can talk about the research study. So I recently got funding from RPLA and the NIH to definitely get more in-depth about male factor. And as a follow-up to that, once we establish that it does cause recurrent pregnancy loss in some patients, then we can work towards treatment. So I think it may be a little too early to really suggest like, oh, we're going to treat it right now, because we just need more information about how does it relate to recurrent pregnancy loss.
Thank you.
Yeah, you're welcome.
Oops. There we go.
And I really wanted to end, and I think Megan she's gone through so many losses. There's always hope. And I put this, I tell patients, they've actually looked at this data. And so this on the right here is basically showing the years elapsed after your first consultation as having recurrent pregnancy loss. And then the different lines, like the green is 6 or more pregnancy losses. And you can see here that, most women will end up with a baby. So 50 to 60% will end up with a baby. And I always tell my patients, it's really how many losses you can go through before you get there. And so, and obviously it depends on age, and sort of how many age is obviously an important factor. Because older women are more likely to have miscarriages, that there's something wrong with the baby. But even in younger women who are like facing their 4th or 5th loss, they lose hope and say, is it ever going to happen to me, Dr. Mak? And I'm like, the literature really suggests that even if you have 6 or more, your likelihood of having a baby is 50%. So, I think the most important thing is, I tell my patients never to lose hope. And, even if it's unexplained, it's just that we don't have the test to say why you have it. But obviously there is something that you have, but we just don't have that test.
Thank you, Dr. Mak. I really appreciate that. And it's such a helpful overview to hear. There's so much that's involved in this. I posted that quote that Dr. Jenkins said at ASRM, where he said, this is the most complex, complicated, multifactorial condition that he could think of. And I think what you just going through all of that, like you pointed out, it is really complex and there are so many things to look at. So thank you for that overview. I'm going to talk a little bit now about some of the emotional pieces. So what's the perspective what's my perspective? What do I wish I had known? Because obviously I speak for myself, and we all go through this experience and have our individual feelings about it. But I just wanted to share some things that if I could talk to myself back in 2015, what might I say? And I'll go through each of these in a little more detail. But first, this was not my fault. My feelings were completely normal. Everything I was feeling was normal. I wasn't alone, even though I felt completely alone. And just because there's more that I could have tried didn't mean that I had to try it. So I want to start with this again, because this is not your fault. This is not your fault. And I know, because I did it to myself, right? It was and I still, even now, even years later, I still sometimes can find myself in that thought spiral of being I don't know, on that last pregnancy, I was feeling tired and I took that long walk, and I shouldn't have taken that long walk. I should have just rested. Not your fault. You did not lose these pregnancies because of your actions, because you moved the couch, or you had a glass of wine before you knew you were pregnant, or you forgot to take your prenatal vitamin that one morning, or you told your friends, and so somehow the universe jinxed you and you shouldn't have told anybody because then it would have worked out. Or, oh gosh, you drank too much caffeine, you knew you should have cut out caffeine. Or even the worst one that seeps in there, somehow God doesn't want you to be a mother, you're not worthy enough. None of these things are true. It's just that there's so much that you can't see or can't understand about what's going on. And so all we do is we focus on that little piece above the water that we can control. And we think, oh, if I can just control this perfectly, then everything will work out. And it's just not true. It is not your fault. Secondly, everything you're feeling is normal, even though it's really messy. So we, as an organization, Recurrent Pregnancy Loss Association, did a research project a couple years ago with the University of Chicago, and we did in-depth interviews with 30 people that had gone through recurrent pregnancy loss, and we identified what were sort of the themes of that experience. And so here are the 5 themes that came out from that. Is this theme about invisibility and isolation. Like, it's so isolating. This feels so alone. um, I've talked to many people and they say to me, you're the first person I've ever spoken to that has had as many losses as I've had. We do exist. There are people that have shared this experience, but it feels so isolating when you're going through it. A lack of control. Like, of course you feel out of control because what you're trying so hard to achieve isn't working. And that is incredibly frustrating and um, disappointing and enraging. And it's so hard to sit in that place of like wanting something to happen and not really being able to know that even if you take all the right actions, you're going to have the outcome you want. Um, Compounded trauma. So one of the things that they talk about, and this is kind of like going over to the right hand side of the slide of trauma is real. When you're going through recurrent pregnancy loss, oftentimes you're getting pregnant again before you've fully grieved the loss of your prior pregnancy. And so this sort of grief builds on top of itself, and it really can lead to legitimate um, mental health challenges like anxiety and PTSD and depression. And so I want to say, like, it's okay to ask for help. I take medication every day, and that's all right. So ask for help when you need it. Um, the other thing is that it is normal. This kind of takes over your mind share and impacts every area of your life. Like, you're thinking about it when you're at work, you're thinking about it when you're at home, you're thinking about it when you're out with your friends. Like, it does have a way of sort of seeping into your thought process, and that can feel really overwhelming. And so I just want to say this is really hard, and you're doing the best you can, and nothing that you're feeling is inappropriate or wrong. And all you can do is try to take the best care of yourself given these really messy circumstances that you find yourself in. And to that end, even though you feel alone, you are not alone. Um, there are a lot of ways that you can start to get some support for this if you feel like you need it. Um, I so one-on-one support. So there's fertility coaches. There are therapists that you can see individually, or couples therapy. You know, when in the kind of height of all of our losses, I was seeing an individual therapist, and my husband and I were going to a couples counselor because, as many of you might know, you grieve this differently than your partner does. And so sometimes having somebody that's looking at both of you together and work through this difficulty can be really helpful. And there are also grief doulas now, sort of the people that are specially trained to help you in that postpartum period when you're feeling grief. Um, there's also a lot of group support. And I put this over here because I sometimes find it really ironic because now I lead our Recurrent Pregnancy Loss Association support group. And yet when I was experiencing my losses, I never went to a support group, which I find funny, but it's because I really thought it was going to be like this picture up here where it was like, oh no, I'm doing everything I can to hold myself together. I have no space for anybody else. I thought that that would be really overwhelming. In reality, I think it's more like this, where it's like the load is lighter because there are many hands and you feel less isolated. And so even though it might feel really vulnerable to try it, you might find that a support group is really helpful. We have one, Resolve New England has one. There are many other organizations that have support groups. I list a lot on our website. There are also some fertility membership communities like Fertility Rally, Rescripted, I think. So there are some that you can find that might be supportive that way. And then there are a plethora of Facebook groups and social groups and things like that. And then before I hand it back to Dr. Mak to talk about research, the last thing I want to say is just with all of this, your path is your path. So this is really difficult. When I like, I think my lowest part was probably like 2018, 2019. I had many, many losses at that point, and I would just get absolutely enraged when people would tell me to have hope and that it might work out. So for me, it was really important to say, hey, it might not work out. So I want to say that to people. It might not work out, and it might not work out the way that you planned. You will still be okay, and your life will still be whole and complete. That said, it might work out. So the only thing that you can do is decide, based on the information you have, what's the best path for you and your partner. And you don't need to justify that to anybody else. There may be more things that you can do, and you may not want to. Just because there is more doesn't mean you have to do it. And as Dr. Mak said, like, yes, even if you've had many, many losses, there's still very, very high likelihood that you would end up with a baby. But I want to also I also want to be honest about, we all have our limit of how much we can take. And so I'm not trying to paint either a positive or a negative picture here. I'm just trying to say, like, this is hard. And you really are the person that's in charge of your own journey, and you don't have to defend or justify it to anybody but yourself. And we're here for you. RPLA is here for you. I understand the difficulty, and I'm sorry that you're going through this. All right, switching gears, I'm going to pass this back off to Dr. Mak to talk a little bit about some of the research that's going on, and how you can get involved if you want to. So I really am a huge proponent of being involved in research, because like, I want the answer. I want to find what's going on. I want to try to, solve it. Nope, but it's not for everybody. However, I encourage people, if you're interested, to join some of these studies. Okay. Go ahead, Dr. Mak.
Thank you, Megan. And I think just sort of talking about the emotional side, I think for me, as a provider, I went to a bereavement course, and I think that really helped me. I think it's very difficult for a provider also to be as supportive of their patients if they don't understand the kind of what patients go through. And I think another thing that, for me at least, is when I have a patient who has a loss, what I usually do is that we don't talk about management. I want them to grieve. And I remember why I started doing that, because when I was part of another nonprofit called Hope After Loss, one of the presenters for the gala, they said that basically when they had their loss, their physician, the only thing they said was, sorry for your loss, but we can do this thing, or this thing. And she said they never really addressed the emotional side. And I think, taking care of patients with recurrent pregnancy loss, you really have to address the emotional side because it's so important. So I think for me, that's what I've taken away from sort of interacting with patients and surveying patients what they need. So I think the emotional part is like as important as the actual clinical part of it. And so I think that when you have a provider, please, you have to feel comfortable with your provider. And if that's not the right provider, find another provider who can give you that support that you need, because I think that's so important for, especially in recurrent pregnancy loss, that you need that provider who will be there for you and who will be supportive. I tell my patients that when they're in a pregnancy, I tell them, you will never be not anxious until that baby is in your arms. And I said, that's okay. This is totally normal. You are okay to come in and send me a message or every week. So a lot of times patients, before they come for their other ultrasound, they're going to have so much anxiety. And so we get on and do the ultrasound. Let's not talk about anything. Let's do this. And then it's like, breathe, relief, that there's a heartbeat. So I think, finding that right provider who can support you is also very important, because as we see from the study of just supportive care can make a difference for patients. So I think I wanted just to follow up from, Megan's, so important to have people share their experiences, because so many people who have recurrent pregnancy loss feel like no one else is going through this. But obviously I see a lot of patients with recurrent pregnancy loss, so I know that, and sometimes I sort of connect my patients who, and they found it really helpful. But sort of going on to my passion also is the research. So RPLA was able to sponsor, partly sponsor the sperm and recurrent pregnancy loss study. And I also, in the same year, got a large grant from the NIH to study this, because they are obviously really invested to understand, because 50% of patients don't have an answer. So we're in the sort of beginnings. So basically I'm trying to study kind of what's different about the sperm from recurrent miscarriage men versus those who, are just controls, who are the donor sperms that are our controls. And we're looking for couples who have had 2 or more losses. And so far, everything has been normal. And so for partners, all they have to do is to fill out 10 questions on their health. So it's a sort of, and then also, usually most women are my patients anyway, so we already have their question, like sort of health issues. And then sperm is what we need from the men. So that's kind of really the long and short of the study. And I think right now we are going to be actively recruiting, but I think for these studies, the easiest would be to contact me and say you're interested, and we'll find out, how we can logistically work this out for sort of out-of-state patients, because I'm based in Texas, but I also will have other centers, Northwestern and Yale will be also other centers. So we're really excited, and it's a 5-year grant, and hopefully we'll find more answers for patients on men and their involvement. All right. And then there are 2 other studies that are already been going on for a few years. So I'm part of a multi-center called the Genomic Predictors of Recurrent Pregnancy Loss. And so this is to really find genetic causes. And we talked about sort of abnormal chromosomes, but that's just really a higher level sort of look at genetics. But the Yale study will actually, when a patient has their second loss, we send off the miscarriage material to Yale. And ideally, we have blood samples or saliva samples now we can collect from mom and dad. And then basically, they're going to look for sort of the known causes, i.e. if it's an abnormal aneuploid loss or abnormal chromosome. And if it's a normal chromosome loss, they're going to get really detailed into sequencing the entire genome of mom, dad, and loss. So we're actively recruiting. Yale has a website, and Dylan is the research coordinator there. But we have 10 or 11 other sites. So, I know this, people will be, sort of from all over the place. So you can see the list of the other centers who are also part of the study, and then you can contact them. And if you're having your second, a second loss, and you have, and you're about to send them off for chromosomes, you may be able to be part of the study and get even more in depth. And so the positive side is that if they find anything that could be sort of causing the loss and it's something that's known genetically, they can share that information with you as well. And then I think, Megan, maybe you can talk about the HOPE study. This is a Stanford study, and I know that the HOPE study and the Yale study were both jointly funded at the same time by the NIH. And so they are also looking at genetic causes, but they also have looking at other aspects of the pregnancy loss. I'm not sure, Megan, if you have a bit more.
Yeah, I'm not. I mean, I only sort of what I've heard and repeat from Dr. Lappy. But what I will say, so the HOPE study has sort of multiple components. So the one that specifically relates to recurrent pregnancy loss is called the TRIOS study. It's similar in some ways to the genetic predictors of recurrent pregnancy loss, where they are recruiting trios, meaning they want DNA samples from mom, dad, and baby to try to identify sort of single gene issues that might have led to the loss. Additionally, the HOPE study is trying to collect information from really anybody that's had even just one loss. And they're trying to do some predictive modeling around that. So if you are interested, they also have a website, and you can email hopestudy@stanford.edu to learn which particular sub studies within the larger HOPE study might be the most relevant to you. And then lastly, I wanted to put information up about one of the things that RPLA is doing. So we have an RPL community registry. Basically what this is just a portal that you create a profile in, and then it allows you to answer health surveys. But what it can do is provide anonymized data based on those survey answers to doctors and scientists that are studying this. And that can be really helpful because, you know, we're a very heterogeneous population. And so to be able to kind of sort through all of us and say, hey, this group of us had similar things that were happening, and this is what worked for us. And this other group here looks a little different, and this is what worked for them. That can be really helpful in trying to accelerate towards finding answers. It's HIPAA compliant, it's GDPR compliant. You can join. I would have no idea that you joined. So I don't know who's in there. I can only contact you through the portal. It's very secure. If you'd like to join that, you can visit our website or scan this QR code right now. And with that, I will say thank you. And please ask any questions in the chat, and we will do our best to answer them.